Good evening, everybody. My name's Craig Comrie. I'm the Principal Officer of Profmed, and so we welcome you to our NHI discussion this evening. We're hosting Dr. Simon Strawn, and we'll introduce him in detail later. I see there are many that have registered for this evening, and I'm sure that in the next few minutes they're going to be joining and will enjoy the evening with us. I thought as a start, just to quickly review some of the things that we've been talking about in the last three sessions of the conversations about NHI. We really have tried to find ways just to empower members around the conversations around first the legal framework, the positioning of the Medical Schemes Act, and then also understanding the detail of the National Health Insurance Act. And we had people like Esme Prince van den Berg share quite insightful information on how these acts are set to work together. We've shared the Profmed views in terms of the National Health Insurance Act and specifically around the planned constitutional challenges that are set to be launched later in October or early December or early November. We've spoken a little bit about the drivers of cost within the healthcare environment, specifically the makeup of healthcare inflation, and that drives the conversation about affordability and the need, regardless of the NHI Act, that we need proper reform within the healthcare system that we have. Tonight, our session is really going to talk mostly about the impact on the provider community and the healthcare specialists as well. So just a quick view. I'm sure everybody has been riveted by the debates that have happened over the last few weeks around the NHI. We know there's almost nothing said about the NHI without a conversation about the GNU and the sensitivity that it brings to the government of national unity. However, we're excited about the compromise. You'll see the heading in the Daily News talking about President Ramaphosa looking at some type of compromise over NHI, and we hope that it is a proper discussion regarding the changing of the NHI Act, specifically the role of medical schemes and the constitutional part that talks to specifically the choice of individuals and how they access healthcare going forward. I note a few hands, and you're welcome to put up hands in the interim. We are going to take hands right at the end of the conversation. So if you can, please use the chat function. You're welcome to also put your questions there in the interim, but we are going to leave some time right at the end of the presentation just to then get engagement, and hopefully we can answer most of the questions that are posed. I guess in the healthcare system at the moment, there's a sensitivity around the dealings between the president and the minister, and whether the invitations to consult with business are proper invitations and genuine invitations to actually find a proper compromise to the NHI Act. And we're looking forward to taking those invitations further and playing our part as Profmed and as part of BUSA, which we belong to. They will also represent us in many of those conversations. So I think one of the assurances that we constantly want to provide to members is that medical schemes are here for the middle and even long-term future as far as we can tell, and that we will continue to fight for the interests of medical scheme members and even the health consumer at large. So you'll see this in the News 24 release this morning. So it does look like hopefully the Minister of Health will come in and open doors for us. One of the things that we do know and understand is that the success of any healthcare system depends largely on the healthcare workers, those that work in the trenches, those that work at the cold face of healthcare. We learnt how important these individuals are during COVID, and so our focus this evening is to turn to specifically Dr. Simon Strawn, who represents the South African Private Practitioners Forum, and he's going to share with us some of his own views and SAPPF's views on national health insurance and some of the other real smart initiatives that he's pursuing and hoping to change and influence the direction of healthcare in South Africa. Dr. Strawn is, as from an introductory perspective, is a pediatrician, been in practice for over 28 years. I think he has an immense talent of bringing groups together, and specifically the specialist groupings together, to talk about things like or confront things like COVID, and certainly NHI. And one of the initiatives I'm sure he'll be covering is his initiatives on coding, which certainly facilitates how medical schemes engage with providers as well. So other than being a Liverpool supporter, we'll hand over some time to him, and he'll share some thoughts on the impact of NHI on the provider community. So thanks, Dr. Strawn. If you are available, you're welcome to share your screen, and welcome to our forum this evening.
Thank you very much, Craig. I hope you can hear me, and is my screen showing? Should be.
Yes, it is.
Right. So thank you very much. Thank you very much for the invitation, and hello to everybody who's joined the call. So I'm going to spend the next few minutes talking about what we think the impact of this NHI Act may have on health professionals in the country. And just to position where we are, the South African Private Practitioners Forum, SAPPF, is a voluntary membership organisation. Membership is usually made up of groups within disciplines, as you can see on the screen. And we have just over 4,300 members, and we were constituted back in 2008. So when we look at this, the first thing to ask is, how familiar are people with this? This is some data from a study, a survey that we have recently completed. And interesting to note that 60% of respondents, and there were just over 1,000 respondents, were somewhat familiar with the NHI, with a very smaller percentage of 25% saying that they were very familiar. So important to have these kinds of discussions, which may be to some on this call a little too much in the weeds, and for others it may not touch exactly what you want to talk about, but I think it's important information. When we talk about how is it going to impact healthcare professionals, one of the first things people expect to hear about is, well, are doctors leaving the country? So in this particular survey, you can see on the top left, they emigrate from South Africa, where we have about 55% saying that they would consider emigrating, or probably would consider emigrating as a result of NHI. But I think this slide tells a little bit more of a story, where you ask around, so what actually would you potentially do then if you weren't going to emigrate? So close your practice, pursue a different career. And you can see there in the blue is definitely and probably. And the significant number of respondents who have indicated that they would in some way or other leave the space. And that I think is critical. And we look at reasons why you would leave the space. I mean, clearly the questionnaire as it was worded was around NHI. But I think we all understand that the healthcare and health reform is but one of the social determinants of health. And when you live in a country where we've had the energy problems that we've had, the infrastructural problems, the road problems, the water problems, the NHI could be viewed as just another one in the litany of reasons why any person living in the country would question their decision to stay or leave, and may well then decide to actually leave. Remembering that we are, all of us in our own right, both citizens of this country, patients in this country, and we happen to be healthcare providers as well. And as we've walked along this line towards NHI, I've always drawn a very strong line, not such a fine line, between NHI and health reform. And when we talk about NHI, we're talking about an act that is a funding mechanism to achieve universal health coverage in this country. And we firmly believe that you do not need the NHI to achieve health reform. We all understand what's required in health reform in this country. We have all either currently work or have worked in the public sector for many, many years. We have colleagues and friends who work in the public sector, if we don't at the moment. And I've always felt along this journey that there's a bit of a persuasion and manipulation. I mean, there's nothing about it that's made me nod my head in agreement at any time. And I felt that as we've walked along, we've kind of headed more towards manipulation than we have towards persuasion. But I think that dichotomy is something that we must keep in our mind. Because to achieve universal health coverage in this country and to achieve that access, quality, sustainable safety, we have to deliver a health system and move a health system from what it currently is to what we desire it to be. And the point about this is that we need to participate in the process of how we get there. But the NHI Act, as it currently stands, we believe, is not the vehicle to get there. And if you're a real cynic, I guess you can follow this quote from Lawrence Peter, who says, if you can't keep up, drag them down to your level. And I've certainly heard in certain fora the discussion around the scorched earth theory, which is bring everything down to brass tacks, let everybody suffer, then everybody will complain, and then everything will start getting better. I look at it this way and go, if we are really looking at this level of metamorphosis in the health system that we require, going from the caterpillar to the beautiful butterfly, what you need to start off with is the environment to allow this metamorphosis to happen, number one. And number two, you need to start with very good genetic material in that caterpillar to end up with a butterfly. So as a pediatrician, you can be glad I didn't show you the stages of gestation for this. I chose the caterpillar to butterfly. But I hope you get my point. And if you look at this, you can decide for yourselves where either your thinking is perhaps along this journey, where the country is along this journey, where health reform is and what we need to do to create this level of metamorphosis. So through the process, SAPPF has been very vocal and has been participating in submissions at every single platform and a lot of media. And our main concerns I've listed down the left-hand side of the screen there, and I've put on the top right unconstitutional, because that really is where the crux of any kind of legal challenge is going to sit, is that there are many elements of this that are unconstitutional. And what you'll also notice is that we have tried very hard to make our submissions about our rights as healthcare professionals to continue to practice our profession, to deliver quality, cost-effective, guideline-based, international standard-based healthcare, and how that is going to affect our patients' access to that quality care. Nowhere in this am I talking about the cost of it, because I think we all understand. In the survey that we ran, one of the questions was, do you think that the government will be able to fund the NHI? And 92% of recipients said, absolutely not. So along this path, in November last year, I realized that what was missing in this entire debate, in these submissions that we were making, was a unified voice from healthcare professionals. So I managed to put together this collaboration. It's not constituted, it's just a loose collaboration of 9 groups. I'm sure you've read about this in the media. And it's from the UFFP and SAMA to SAPPF and orthopedics and dental association, radiology, obs and gynae, orthopedics, and forgive me if I've left anybody out, but there are 9 of them. And what we did was we developed a consensus view of NHI, which we made available to the media and had a lot of media interaction. And then once the National Council of Provinces had approved the bill and that it was sitting on the president's desk while he was looking for that pen, if you remember, we wrote to the president, submitted to him to please not to sign the bill, to really apply his mind to the constitutional elements that we thought were problematic. And we submitted a very well-written document that was prepared for us through one of the top legal firms here in Johannesburg. So we know that the president assented to that bill. So I'm going to walk through just a few aspects of the bill, and I want to make a very clear statement up front. Our response to this bill is based on the fact that we can only make a decision on what we know. To say that we will wait for regulations and rules, you can't change an act by regulations and rules. We can only make a determination of whether we approve this act, which is now a legal document the things contained in it can now only be changed by an act of Parliament. So the decisions that we make are based on what we know. And what we know, first of all, in the three big committees that are going to be set up, is that healthcare professionals, providers like ourselves, are mentioned in but one of the three. We are not mentioned in the Benefits Advisory Committee, and we're not mentioned in the Healthcare Benefits Pricing Committee. Health economists are, healthcare providers are not. We are, however, mentioned as associations of health professionals and providers in the Stakeholder Advisory Committee. So just on the face of it, looking at the Act, if this is where our position is sitting in terms of any attempt to change the Act to participate engagement, we are really going to have to put our foot down, make our voices very clear, stand up on the platforms, unite together, and make our voice heard. We really have one national health asset, as I alluded to earlier, and the private sector has to be seen as key to the successful implementation of universal health coverage. The private sector is key, and we have to approach this with the determination and reality that there will always be a well-regulated, governed, and funded private sector in this country. Because the reality for the private provider, when the national health insurance is fully implemented, is dire. The difficulty we have is we don't know what fully implemented means, and we don't even know what basket of care is going to be introduced. But this is a law. So if the implementation means that in my field, all of pediatrics now falls under the NHI, that has massive consequence for me as a private pediatrician. If we look at the wording around the accreditation of service providers, accreditation is on primary healthcare services through the contracting units for primary healthcare, the so-called the CUPs. They are for emergency medical services, and they are for hospital services. Nowhere in there is there a mention of specialists or allied health professionals. Hospital services would be all-encompassing, obviously, of people who work within that hospital. But within this, there is therefore no provision for contracting for ambulatory specialists or allied healthcare services. All well and good. You may say, but there will be rules, there will be regulations, we will make it happen. The Act does not say that. And because the Act does not say that, we can make no assumptions or presumptions on this. If you look at the accreditation of service providers, we meet the needs of users and compliance with prescribed specific performance criteria accompanied by a budget impact analysis, meaning that if you're wanting to be a service provider, you may be required to provide a budget impact analysis for the services that you are going to deliver within that system. The services that will be required will be a minimum required range of professional healthcare services and an allocation of the appropriate number of healthcare professionals. This is the certificate of need. So yes, the certificate of need may not be mentioned specifically in the NHI Act. It is mentioned in section 36 to 40 of the National Health Act, but this section of the NHI Act points very strongly towards that certificate of need, which I hope you know at the moment has for the second time in High Court been declared unconstitutional, and we are waiting for the Constitutional Court to ratify that decision. There needs to be adherence to treatment protocols and guidelines. There needs to be adherence to healthcare referral pathways. How is this going to work? How is this going to delay care? How is this if you start a primary healthcare service across the entire country, in a country which from the outset is not a particularly healthy country? By increasing primary healthcare, you're going to increase the need for referral pathways. You're going to increase the need for levels of service above primary healthcare. How is this going to work, and how are the patients going to navigate this? And how is this going to affect access to care and prolong care and increase the queues waiting for services? We have no further detail of that, but we can, because we read and we live in the world. We look at other systems in the world that have similar kinds of mechanisms, and we can see the difficulties that they are facing. There needs to be a national health information system into which all data is captured. There will be a national pricing regimen. So who will determine that? How will we collaborate in that? What say will we have in that? and there will be a clear statement of performance expectation and need. Now, I have been told by various sources that remuneration will be based on performance. Now, it's hard for me to understand how a data collecting system is going to be that granular and that reproducible and that accurate that is going to be able to stratify remuneration levels within healthcare service providers. I can see it being all in and all out. We don't have enough detail. The payment of healthcare service providers at the GP level B will be prescribed as a capitation strategy. We know the issues around that. And in the case of specialists and hospital services, payments must be all-inclusive. So if you're a specialist working in a hospital and you are, let's say, a surgeon, what you will be paid will be determined by somebody else. It will be based on a diagnosis-related group. And when you submit your bill, you will be submitting it along with the hospital bill, the anaesthetist bill, the dietitian's bill, the physiotherapist bill, and there will be one payment will then have to be split. So we already know how global fee structures are difficult already in the private sector with the level of administration that we have currently. So it chills me to think how this is going to operate. And then obviously there will be payment for emergency medical services. The iron triangle of healthcare states that the relationship between quality, cost, and access is fixed. Mess with one, you mess with one or both of the other. And the bill states that procurement and contracting for supply of specific healthcare services, medicines, health goods, health-related products will be negotiated at the lowest possible price. Not the most cost-effective or appropriate, but the lowest possible price. So you apply that to quality and access, there has to be a shift. It is impossible for there not to be a shift in something. So we all know practicing healthcare, we as responsible healthcare professionals, we all work by protocols and guidelines. We all try and make sure that our work is appropriate, cost-effective, and that it can be adjudicated on by our peers because we make sure that we work according to guidelines. But cost is but a part of the decision-making process when determining benefits and treatment guidelines. Where will healthcare professionals be in the determinations of these treatment protocols and guidelines? Because we're not included in that committee. And all funding decisions about healthcare have clinical implications and thus affect the potential outcome for a patient. I think these are critical. And the detail of this is not included in the bill. And because we don't have any detail on this, again, it's very hard to give a nod to it. We're also not sure what's going to happen about medical legal litigation. If you are seeing patients from the NHI fund, let's say it's fully implemented, so all of my patients come from the NHI fund. And my colleague, who happens to work in the state, also as a specialist pediatrician, all his or her patients are also coming through the NHI fund. So we're seeing the same source of patients. But the medical legal risks are different because they have cover and we don't have cover in the private sector. How is that going to work? And it's been mentioned to me many times, what are you complaining about? You're going to have so many patients in your practice, you're going to be clapping hands. And the answer has to be many more patients for at what level of remuneration? More patients, less money, more work. More work means you're hungry, angry, late, and tired. And we know from the MPS that that is the recipe for disaster, for mistakes, and for increasing potential litigation. So with those just as a few pointers that I've taken out that directly affect healthcare providers, the fully implemented scenario for healthcare professionals means that we need to be accredited, not just by the HPCSA, but by the Office of Health Standards Compliance following an inspection. And this accreditation will be done in the shadow of the Certificate of Need. We need the ability in our practices to register users and report, and we need to be able to access and use the national-wide electronic health record system. We will have one source of patients when it's fully implemented, and you will have no say over that. The patients will come to you at the prescribed rate. We will have to comply with the new coding system, which is being implemented, and which is currently the International Classification of Healthcare Interventions, the WHO system, which is very good for data collection, data sharing, but it is not designed as a remuneration platform at all, and it's not used anywhere in the world as a remuneration platform. The remunerations will be either capitation or DRG based, and for specialists, all-inclusive. Exposed to lowest cost remuneration, which will be performance-based, because if you're not performing, you get kicked out. And remember that if we're working in a situation where we have one stream of patients coming from the NHI fund at a cost that is being dictated to us, where we have to comply with all the accreditation, we are therefore nationalized. We are working for one fund, one employer, so to speak. Very similar to what our colleagues in the public sector will be doing. But if we're in the private sector, no employee benefits, medical insurance at own cost, and your own ongoing practice costs. So that's the kind of reality with which we face based on the information we have at hand. And the information we have at hand is the National Health Act. So what is our opportunity cost? How do we weigh this up? What do we do about this? And here I'm referring to what do we do about ensuring that we participate, ensuring that we help the drive towards better quality, sustainable, affordable healthcare for all. How do we balance this between health reform and the national health insurance? How do we balance this between us as citizens and us as healthcare providers? What do we do about it? So the way I've looked at this is, if you look at what the National Health Act says to us, do we need to trust? Do we need to say we trust in the system and that let's give a nod to the National Health Act because we trust it's going to deliver? Well, I like this little quote where trust means there is an element of thorough understanding. Well, we don't have that. So do we just then believe in the system? You say we really have belief that this is going to be achieved, or belief is characterized by the absence of the element of thorough understanding, which kind of sits with what I'm presenting. So do we believe? Well, then we have to look at it and say, do we have a set of successes within our South Africa environment where we can actually believe that things can happen, can be run, can be funded, can be delivered? If we don't, well, then we need to challenge it. And this is where the legal challenges come in. And I put up the constitutional challenge, because that's really what the challenge around the Act is all about. So at SAPPF, we will be lodging legal papers within the next few days. And the legal challenge really is around procedural and substantive elements of the Act. Procedural is around how the Act was assented to and the process to get there. And the substantive elements are the constitutional matters around it. We're thinking that if a decision is made where a constitutional right is infringed, was that decision rational? And were there any other ways to achieve the same result? So I'm not going to say more than that. The papers will be in the public domain within the next few days. The factors to consider around whether you do or don't make a legal challenge. And through the South African Health Professionals Collaboration, not all 9, in fact, only 2 of the 9 member groups are in the process of putting together legal papers. And some of it was around costing, because it's extremely expensive. The other is the role of the GNU. If you do have belief or trust, and that falls towards the GNU, well, we'll have to see what plays out. The reappointment of Dr. Aaron Motsoaledi was very telling. It certainly showed the government's push, very hard push, to back NHI. And as you've heard from what Craig said initially, but I'm sure you've read the media, Dr. Aaron Motsoaledi certainly has not been quiet. And there are many billboards around with a very good propaganda campaign driving NHI. And then what about these potential calls for engagement? Do we proactively seek them, which we have been doing? And BUSA, in fact, this afternoon, a delegation from BUSA actually met with the president. And we were expecting the Minister of Health to be there. We know he was invited. We weren't. I'm not sure who else would be in the meeting. I'm having a 7 o'clock catch up with the team after this to hear how that meeting went. But this really was to say, let's engage, let's halt implementation. The bill is not workable. It is not fundable. Let's find an alternative. and let's find alternative mechanisms to make this happen, including something like some public fund, call that public fund an NHI. So at the SAPPF level, we got an estimate from our legal team. We went through a round of fundraising. We raised a sizable amount of money, which we're just about through. We're now having to go through a second round. And that was through our membership. And we really are calling out to anybody else who feels that they want to put some money towards a legal challenge, to challenge it on the basis that I've been explaining and for the kind of passion with which I'm presenting it. You'll see my email address at the end. I can surely put you in contact. We have suggested that 1,000 Rand from every healthcare professional who feels that they want to participate in this is not a huge ask for something that is as massive as this. If we run out of money, well, then we might have to join another challenge to curtail costs, or we might have to pull the plug. Hopefully we may never get there, but we certainly are on the road to get to the first bus stop, which will be to lodge our papers and have our day in court in the High Court here in Gauteng. So looking back on that opportunity cost, I mean, what are we doing around this, and what is our thinking? So there's no question that to achieve universal health coverage, we need to improve the public health sector. And as I mentioned, we don't believe that you need the NHI to achieve that. We just need better governance, better fiscal discipline, removal of fraud, waste, and abuse, et cetera, et cetera. But what we do need is a unified voice for collaboration and participation, so that when we reach out to government, we're reaching out as a united group of healthcare professionals. We really need to be doing this. We need to make sure that even though we may have some differing views, that in the main, there are many views with which a lot of people align. And even if we're starting from that, we need to make it clear. And I have no issue whatsoever in stepping into an engagement with the National Department of Health on the basis that we are challenging it, but I'm as equally passionate to make things work. The NHI is not the vehicle. It doesn't mean we're not going to participate. In the private healthcare sector, that means we need to have a look at these health market inquiry recommendations. If you go into a room of private healthcare professionals and you had to ask the audience, what are these recommendations? Because this comes off the tongue glibly in so many meetings. A lot of people don't understand what it actually means. Sure, one of them is outcomes monitoring and reporting. There are many other things in the funding industry around risk equalization, about low-cost benefit options, about increasing primary health care, about getting a single basket of care, about extending that into the private sector. There are many, many things that came out of the health market inquiry that we know will benefit the private sector, but we have to show that if we are expecting the public sector to do things, the private sector needs to step up now, and we need to start doing things. We need to seriously look at this fee-for-service model in which we work and acknowledge that it is cost-driving. And we need to find ways to move away from that, not just to alternative reimbursement models and global fees. They need to group practice culture. We need to create a culture so that when young doctors are coming into the private healthcare sector, that they are not looking for that tiny little piece of turf to create their own empire, that we create the possibility for them to join multidisciplinary groups and to join group practices. And by that, I don't mean multidisciplinary group. I'm meaning 5 or 6 pediatricians together in one geographic location and create a center of excellence. We need to create possibilities for multidisciplinary teamwork. There is no mechanism within our funding industry to fund for multidisciplinary teams. So again, in my arena, there is no mechanism that will effectively remunerate for a neurologist, a pediatrician, an orthotist, a physiotherapist, a dietitian to sit and have an hour-long discussion about their cohort of cerebral palsy patients. That's ridiculous. We need to make these things happen, and we need to be engaging with people to make it happen. We need to develop employment contracts. We need to take charge of this and say, if the government, if the department comes to us and wants to contract with us for specific services, do we have a service level agreement that we agree on as healthcare providers? And we go, let's use this as a starting point. Do we have an employment contract so that if the HPCS say, Ethical Rule 18, once it has gone through the process again, because it's been rescinded at the moment, once it comes back, because it will come back in a different view, have we developed an employment contract that works for us? We need to be doing this. We need to improve the coding scheme so that it more effectively represents the work that we're doing. We need to participate in the discussions about the Department of Health bringing in a national coding scheme that is not fit for purpose as a remuneration model. How do we participate in that? How do we make it happen? Do you know that if you ask any audience of healthcare professionals in this country, less than 25% use electronic health record keeping in their practice? We have to change this. We have to find mechanisms to educate people. We need to get providers of electronic health record systems together to educate people, and we need to be able to then integrate these systems, integrate them into one national system, if that's the way to go. We have to have one database in this country. We need to have things that are portable, and we need to have things that are able to cross-reference and that can integrate. And we need to be doing this in the private sector. So one of the big things we're doing around coding is at the SAPPF level is we registered in 2008 what we call SACCI. I mentioned ITCHI earlier, which is the WHO model. The Australians have their model called ACHI, and this is SACCI. So it's like itchy, scratchy, ACHI is sneezy show. But what the idea is, that is we create a democratically appointed, multi-stakeholder, centralized regulatory framework for coding with overarching good governance, with a unified and nationally accepted process for the implementation of new codes, revision of existing codes, and for resource analysis to ensure appropriate and acceptable funding before publication of a coding manual. Now, yes, SAMA does some of this already. Absolutely right. And SAMA is aware of this. They are participating in this process, and the systems that SAMA had will be utilized. In terms of developing codes, now this is the organogram. There will be a board made up of healthcare providers, funders, regulators, and there will be these pillars underneath it. So SAMA and the work SAMA does and the work that the various disciplines do, because remember, coding is owned by the healthcare professional. The descriptors, the clinical application, the coding consultants, making sure that it is crosswalked to international coding systems, that it is verified, is done through the disciplines, and that's what SAMA does at the moment. But the idea of this is that when a code comes in, or a new coding system comes in, or a code needs to be reviewed, or an RVU is being reapplied because it hasn't been reevaluated for years and years and years, that the funding industry, that the policy regulatory industry has sight of this from the start of the work. So they can go through this and it can be open collaboration. And yes, it's going to mean funders sitting in the same room together, doing one health technology assessment, having one actuarial evaluation, hopefully having one utilization process to streamline it, to cut out duplication, so that by the time a code is published in the SAMA medical doctor's coding manual, we know what the funding industry's decision on that code is. And the start of this is the premise that if there is a scope of work that is represented by a relevant code with a good, appropriate descriptor that has an RVU attached to it, it is unacceptable for the funding industry to say that they will not fund it. You cannot say you are not going to fund a scope of practice that is international best practice. So then what happens is there's a discussion around how do you then fund it? What processes? What alternative reimbursement model do we need? What outcomes monitoring do we look at? What kind of profiling project do we do? What proof of concept do we need? And how do we then make it affordable within the industry? So we're looking then at what it really means is an independent coding oversight, effective and streamlined review of codes. All parties participate in initiation of a review, ensure accuracy of descriptors, ensure appropriate RVUs, strategic funding reviews, opportunities for alternative reimbursement models, and value-based care. Data sharing facilitates the development of outcomes monitoring, and there's a coordination at a national level. I have presented this nationwide for the last 9 months. I have not had one dissenting voice, not one serious dissenting voice. I've had discussions with some people. I presented this to HFA, I presented this to the Board of Healthcare Funders. And I've actually left a bit of a challenge. with them to say, tell me how you're going to make this work. If you like this idea, if you think it's a good idea, how are we going to get everybody to sit in the room together and actually make this work? And that's the piece of work we're busy working on at the moment. So to go back to then, victory comes from finding opportunities in problems. I believe that it is quite acceptable to, on the one hand, be mounting a challenge against the procedural and constitutional elements of the bill. But it is equally necessary for us to participate in healthcare reform in this country, that we are able to deliver universal health coverage that is equitable, that is sustainable, and that is financeable. So, and now this is the balance. The opportunity cost is to collaborate on the one hand, to do it despite what we're doing around the constitutional challenge, to be transparent, to develop partnerships and to support each and every one of us so that we can create a healthcare provider community that is easily identifiable by people making regulations. So one of the biggest problems in this country at the moment, it was the biggest problem during COVID. Anybody at the national level who was looking for help from the private sector didn't know who to come to in the healthcare professional space. That is why we so often get lumped with the hospital groups, and the hospital groups then come and tag us along. We need to reverse that. We need to be able to collaborate to a point of view where we are easily identifiable, the leadership is identifiable, our objectives and our belief in the system and our passion to make it work for South Africa is obvious to everybody. Craig, I'm going to thank you, and I'll stop there.
Thanks, Simon. I appreciate the passion behind how you present and your important thoughts about the role of the healthcare professional. We have different terminology sometimes in the funder space, but we also recognize within a Profmed membership base, the reason we felt it so important to have you speak to us tonight is that 18,000 of our 34,000 families are healthcare professionals. And so it really is an important overlap. And in the NHI conversation, what we've noted specifically is that as medical schemes, we seem to have a vested interest, as if that's a negative thing. But you also, as healthcare professionals, have significant vested interests in the whole NHI program and process and reform into the future in South Africa. And so maybe I'll start with a question, and then I'll get to some of the hands that I saw go up during your discussion. But maybe the conversation is, there seems to be so much complexity within the NHI Act and how it applies to healthcare professionals. What would you have had as a way of almost enticing healthcare professionals, or almost a retention strategy of getting health professionals involved in the NHI type of system going forward?
Okay, so I think to answer the first point, I mean, yes, the NHI Act is vague on implementation, and because it's vague, that's why we can't do it. And that's part of most of the legal papers you'll see is the vagueness of it makes it irrational. So through this journey, you know, we have to acknowledge that healthcare professionals actually do have some insight and actually can contribute significantly to the discussion. So it would have been very important from the outset to get the healthcare professionals in the room together, public and private. The second thing is the thing about the NHI Act is that it immediately alienates a section of healthcare professionals by saying that you're not actually that important, and we actually can, you know, we'll kind of use you, but we'll use you as puppets along on a string. We'll tell you how we go, but there's no chance for engagement. So it's a bit like, you know, Craig, it's a bit like these learning things we do when we have a difficult case. When you have a difficult case, you know, you go and do your own research, and the very next thing you do is you start looking for help. And you create a team of people to sit down and go, let's collectively think about what's best for this particular patient. So if you want to regard our healthcare system as a patient, it's very sick. It's in high care. It might even be in frail care. So you need to have a multidisciplinary team across the board of really informed people who participate in that, and you have to apply that kind of thinking to it, that transparency in it, so that people can feel that they actually have a role to play and that they're being heard. And we don't feel like that. In fact, I thought about the other day, you know, that in terms of the wellness that's going on and the mental health disorders that healthcare professionals, we use the term moral injury. I'm feeling like that a bit about this. I've literally been slapped on the side of the face and said, nah, we're not really listening to you anyway. You're going like, okay, let me stop.
Yeah. No, I think it's important to know that you have the voice, that you're engaged, and it's good that you've been part of some of the invitations and responses to the invitations on the NHI discussions. Perhaps I'll start off, and I'm going to just reference one of the questions. I think it initially came from Tony Berman. Tony just indicated, is there any opportunity to discuss the HASA proposals that came through at the recent HASA conference? I think most of it was piloted by or in the media through Richard Friedland. And my first response to that would have been that if you read probably 10 of the different submissions made to the Health Portfolio Committee, that was years ago, now 2 years ago, they all contained almost all the aspects that Richard had in his alternative model. So these aren't new concepts. It's always interesting to see the response as if it is a new idea to have mandatory medical scheme membership, which is the Health Market Inquiry recommendation. But the model deliberately and quite specifically indicates that if you have more people in the private sector, you leave more funding, more capacity, you improve access in the public sector, and that would go a long way to improving the current metamorphosis into whatever NHI or universal-based system we want to look at into the future. So I do suggest that if you want to take a look at the model itself, there are probably two papers I would look at quite closely. The one is the submission by the Health Funders Association, and the other one by HASA themselves, which had a lot of that content included in the submission to the Health Portfolio Committee. So please take a look at those papers. You'll find that it is a very real way to achieve universal health care a lot quicker than you can see the number of complexities we have to navigate through. Probably, I see in a recent comment, I think it was the Sanlam CEO saying probably in the next 50 to 100 years was his comment. And so that might be sooner than even I suggest would be realistic. So I think in terms of those models, these aren't new models, but the answer to an alternative structure which preserves the parts of the Constitution and choice of the consumer lies in those very answers. So it really is important to make sure that there's both reference to improving access and equality in healthcare, but that you preserve the rights of choice for the healthcare consumer. And so there are different models and ways to get there. Maybe the other interesting part is the various constitutional challenges that are going to be submitted from different parties, including HASA, the BHF, and the Health Funders Association, which Profmed is part of, relies quite heavily on the health economics and modeling behind that. And what the submissions are going to do is actually make sure that there aren't any contradictory items in the models presented to the Constitutional Court. So there's lots of correlation and coordinating in the background to make sure that there is a consolidated alternative model on the table, which does not compromise the constitutional rights of members of medical schemes or individuals who pay for healthcare out of their pockets, or even for individuals who can't afford to pay out of their pockets for healthcare at the moment. So it is quite a comprehensive model. And I would suggest, Simon, as soon as your papers are filed, there'll be some interesting reading, because then we've had Solidarity file papers a while ago. The BHF is challenging specifically the decision by the president to ascend the bill or sign the bill into law. BHF is also planning their other constitutional challenges on procedure and specifically around the constitutional choice and freedom of choice of an individual. The HFA's papers will go in nearer November, beginning of November, and we're going to see a very interesting outlay of all the different aspects of the NHI and the things that the Constitutional Court will have to rely on. So I'm going to move on, and just then I'm going to ask, I did see hands, I didn't see the questions specifically in the chat functions, but I'm going to go to the hands first, and then we'll look at some of the remaining questions that come through. So Andre Swanepoel, I'm going to ask, and we sometimes get stuck here, but there are 300 plus people on the line. So Andre Swanepoel, I'm going to ask our IT guys to unmute you. You had a hand up earlier. Also, Hilton, I didn't catch your surname. We'll ask that you also be unmuted. Shafruddin Ahmed, I know there are a few comments in the chat section, and please, if you would like, we'll unmute yours as well. And then I think it's Angela McKay. We'll do that as well. So as soon as you're unmuted, please just mention your name, who you are, and then share your comment or question. I think while we're doing that, then I see there's a comment by Dr. Yaqub Omar Karim. Can you criticize the following statement? It says, in the funding model, it's very difficult to see where the investment in infrastructure, equipment, and space capacity will be funded. It appears that only labor and some consumables are funded. I guess that talks to the funding model or the reimbursement model for specifically facilities and healthcare professionals. I don't know, Simon, if you want to try and answer that, okay, and comment on that question.
Yeah, I can try. I think that it's certain that the Act is very vague on funding infrastructural development. It's much more about procurement of services, single procurement, single funding. But contained within this is that to be accredited, you have to comply with the Office of Health Standards Compliance. So wrapped into that is there's going to have to be infrastructural reform. So again, that's one level of vagueness that is a problem. And you can look at the current system and go, well, some people say, there is already universal healthcare in this country. Everybody has access to healthcare at a clinic. It's just poorly distributed and poorly delivered, and because of infrastructural. That's a bit of an aside. But yeah, I think the point is that the Act is full of procurement, suggesting that's where the money's going. So you're absolutely right to raise the question, so who's going to fund the infrastructure?
Mm. And that fight for the lowest remunerated process is certainly going to ignore some of the infrastructure, which then, I guess, in a government context, it's a typical government type of an approach where infrastructure is covered by public service or another ministry. And so it doesn't come into the conversation, but in a private setting, you have to have a return on investment. And that value proposition for investors is still going to have to be there if we're going to create the access.
That's right. And I mean, even if the thought is that over the next decade, all that's going to be rolled out is a very thin layer of accessible primary healthcare across the country, if that's what the intention is, they're still going to need more money. So then there's no money bill to get that. So what are we going to be funding that? And out of that, then, the important point is that if you achieve that in 10 years, the Act is still legal. So they can complete all of it, and all of it's still there. So if you don't challenge it now, it's still going to be on the statute books.
Yeah. There's another question, Dr.
Craig.
Hi.
Craig,
Yes,
I'm
let's
Andre
pause.
Swanepoel. You asked me
Yes,
right
Andre.
at the beginning, and I'm now unmuted.
Great.
Yes, I'm a practicing law in Windhoek, Namibia. So I'm dialing in from far. And I've listened to everybody and to Simon, which was a very interesting discussion. And I cannot believe that any bill has passed as an act, given all the circumstances. My big concern, and that is purely personal, and it comes from where I sit in Namibia, as being a member of Profmed since 1978. So I might have been the longest Profmed member sitting here tonight. But and being in Namibia, we were always serviced and rightfully by Profmed, which I never wanted to disengage and enter into a new medical scheme in Namibia from a patient perspective where I sit as a professional. And I do not see any engagement with us sitting here in Namibia, whether we will be disconnected when this legislation comes into place, whether we should now seek for other medical schemes currently operating in Namibia, or what would be our position? At my age, at this stage, the point in time, it would be very difficult for me in any event to get accepted to any other medical scheme. And to go through that legislation as a patient, I dare to say that I'd rather die here in Namibia.
Yeah, thanks, Andre. I thank you. You're one of, I think we have just over 200 remaining members still in Namibia that enjoy cover, and certainly we will not lose track of you and continue to provide services to you. What I can assure you is that this is going to be a very long journey. So despite the legal challenges that are set to commence, the implementation of the Act, even by those that are controlling the implementation, is set to take many, many years in terms of its implementation. And it's really only at the end that medical schemes, and you would have heard the phrase in Section 33 of the Act, it says there would be a time when the minister can declare that the national health insurance system is now fully implemented. So it doesn't actually tell you what that defined is. And that will then be the stage that it'll have a real impact on medical schemes. Our view and the view of the medical scheme industry is that time will almost never come, but that some of the reforms that need to help improve the health system have to happen in the interim. Otherwise, things like healthcare inflation and affordability are already going to be problematic for the sustainability of schemes into the future. And those answers, the overlap in the answers, are in fact quite clear. The reforms that are suggested as an alternative to NHI, the mandatory membership cover, the low cost benefit options, the risk equalization mechanisms, all these reforms need to actually happen regardless of whether the NHI Act comes into play. But it is one way it will keep schemes sustainable into the future. So there's no need, Andre, to panic at this point in time. We think it's going to take certainly more than a few decades to get into place. And in the meantime, you can enjoy your cover as you have been for many years. And thank you for being such a loyal member.
No, thank you so much. And yeah, it's just a concern for us, for me, going to hospital here, even to seeing medical practitioners or doctors, it was always then submitted to Profmed, and they required the codes and whatever, and that it has been paid then predominantly. Yeah. But and surely, being part of the medical scheme, the South African medical scheme, I suppose place there that sort of cuts your benefits on this side, then surely it makes a big impact on us.
Yeah. Yeah, and the assurance is there. I think the case, which is the certificate of need case, is a very important case. That was the National Health Act more than 20 years ago that was actually written into the Act, and then pronounced the relevant section on the certificate of need was pronounced unconstitutional so many years later. So it gives you an idea of how slow these things can happen. And in the interim, just be assured we can still look after you. So yeah, thanks for that question, Andre.
Craig.
Yeah.
Hi, Craig. It's Shafruddin.
Yes, Shafruddin.
Hi, Simon. Thank you for a great presentation. I think, notwithstanding everything that you had to present about the NHI and its limitations and the challenges we face, I think my question will go to the private sector. The private sector requires fixing. For a long time, we've asked for self-regulation in terms of funding, in terms of fee structures. While the certificate of need is indeed unconstitutional, what have we done in the private sector to ensure that, for example, in Durban, KwaZulu-Natal, we have 40 cardiologists serving a population of 800,000 in the Berea area, but we have one cardiologist serving 1.5 million people in the Chatsworth area. So we want to present this idealistic view about private practice, but we need to acknowledge that, you know, we require self-regulation. We also require more communication with the funders. I mean, the funders have taken patients' rights for granted, and we are okay with it. We don't challenge them. We need to challenge the funders in terms of what they pay for, what they choose to pay for, how they impinge on a practitioner autonomy. So while I am in favor of all the suggestions you've made with regards to the NHI, nobody's talking about how do we fix the private sector before we present this model to the government to say, well, it's working. Patient outcomes are not the best in the private sector as well. So for me, that is something that we need to look at. We should look at everything holistically and address those deficiencies in the private sector. Thank you.
Thank you for your comment, Shafruddin. Maybe Simon, I won't speak as a funder for now. I'm happy to hear your response, and then maybe I'll share just a funder's view as well.
Sure, will do. So I agree completely. The trick we have here is that many of the fundamental changes that are required within the private health sector, like some kind of change in the coding system with a reference price list, for example, that can only be regulated, and that has to be appointed by the Minister of Health. If we are wanting to have any changes in structure of benefit, low-cost benefit options, that has to be appointed by another regulatory body. If we want to sit down and discuss how we improve cost effectiveness, and we want to talk about cost sharing, we are in breach of the Competition Commission. If we want to sit down and talk as healthcare professionals, there are so many groups with their own vested interests that it becomes increasingly difficult. If we want to speak to the funding environment, we've got to speak to 72 different funders. So the SACCI model that I presented, I really believe, is the first real attempt to try and get some kind of collaboration where exactly what you're talking about can be brought into that forum and say, how do the funders respond to this? The last little point I want to make is that when we look at what looks like over-servicing in terms of doctor number to patient number in the private sector, you need to try and equate that to equivalent healthcare standards across the world. Is it truly a over-servicing, overpopulation of doctors to patient numbers, or is it actually appropriate? And is it just the dichotomy between the geographic distribution that makes it so glaringly difficult to understand? So there's a lot in that, but I'm very happy to chat to you about it, bring you on board. Let's get our heads together. Thanks.
Yeah, thanks, Simon. It is past 7 o'clock. I know you had another engagement, and we're happy to excuse you if you need to go, and then I'll answer the remaining few questions then as well.
Yeah, so please, everybody, my email address is very simple. CEO@sappf.co.za is the easiest one. You're very welcome. Please reach out. Send me your money if you want to. And if you're not a member of SAPPF, come along. Let's get this done together. Thank you very much, Craig.
Thank you, Simon. Really appreciate your
Goodbye,
time.
everybody. Bye.
Thank you.
Good. Thanks. I think maybe just from a funder's perspective, Shafruddin, I think the issue is the fact that we have an incomplete set of regulation, and you've heard from Simon as well. If some of the regulations were properly amended and there was space for things like mandatory membership, there's been lots of inquiries done over the years. The last one is the health market inquiry, which was almost a 4-year process under the guidance of the Competition Commissioner, which highlighted a whole bunch of things that needed to be resolved. Partially, it was a space where healthcare practitioners and professionals could sit in a negotiated forum, a multifaceted negotiating forum with funders to resolve some of the issues, unlike negotiating with each individual funder as well. So there was lots of suggestions about regulation. The problem was that report has been sitting dormant for the last 4 years, and none of the regulators have actioned on it. And much of it is constrained. So things like low cost benefit options is constrained by the regulator, the Council for Medical Schemes and others. I think we all from a funder perspective, we all in search for more affordable healthcare cover, which we can share with everybody, but it does fall into some of these tied up frameworks within the legal system. In the interim, we need to fight each of the battles as we can. There was another comment earlier in the chat where somebody indicated that there certainly is a problem when it comes to the funding environment, and sometimes the funding, even in the public sector, means that not a lot of doctors will work in the public sector because of the state of the infrastructure or the supplies that are available, or the security in that space. Healthcare inflation, I think, is touching everybody, not just in South Africa, worldwide. And so the result here is escalating medical scheme premiums. So on our side, we see effectively a CPI plus 3 or 4% every year for the next 20 years, unless we change the fundamentals of the fee-for-service models, the fundamentals around getting low-cost benefit options, more people into pre-funded healthcare coverage. If we don't change that, then we're going to really sit with burdening affordability issues in the private sector. In the public sector, that has resulted in underfunding posts, and we've seen lots in the young doctor space, how many unfunded posts there are, but we have doctors that aren't employed. So these are answers that we need to fight for, and we need to change the system, both the public and private system, in the right way. We're hoping maybe the NHI debate is the way we get to implement the right answers into the future. So we'll keep on updating, certainly, our membership of Profmed, keep you close to the constitutional challenges and all the other industry matters that affect the sustainability of the healthcare sector. But thank you for everybody's time. There might have been 1 or 2 unanswered questions. We have a Q&A, NHI Q&A session, and we'll make sure that each of the questions get answered there. It is almost 7:10. Thank you for the extra time, and have a good evening.